Good morning, this is Zuhaib Rashad from second year dentistry and group 3. Hope you're doing well and good, enjoying your time there. Today I'll talk about ophthalmologic complications that occur after intraoral local anesthesia. I found this article on PubMed and this article has analysis of 65 published case reports. So let's begin with a little bit of introduction. I define ophthalmologic complication as systemic and physiological alterations in orbital region caused by various diseases or surgical treatment such as local anesthesia that can cause eye problems with minor changes to significant visual loss. Local anesthetics represents dentistry's most frequent drugs, and intraoral local anesthesia is probably the most frequent of all dental interventions. But complications such as anesthesia failures, hematomas, infections, neural injuries, or adverse reactions are very rare. Our eyes, apart from visual perception, represent components of the facial expression and non-verbal communication. So disorders of the eyesight can actually cause low self-esteem and psychological pressure. The first case reported was in 1936 by dental intervention that caused ophthalmologic complication. Let's see some common types of ophthalmologic complications. I have ordered them in alphabetical order. First of all, we have accommodation disturbance, maurosis, which is loss of sight, diplopia, which is double vision, sorry, and anophthalmos, which is recession of eyeball, miosis is the contraction of pupil, and mydriasis is dilation of pupil. Ophthalmoplegia is paralysis of all muscles responsible for eye movement, and ptosis is drooping of upper eyelid. These complications due to intraoral local anesthesia have immediate to short onset and disappear as the anesthesia is gone out of your body or is removed from the area. These complications are related to anesthetic solutions reaching the orbit or nearby structures. Let's see the material and methods used in this article. All the information given by this article was collected through PubMed search engine, and only English articles that included case report, case series, clinical study, and review articles were selected. This article included a total number of patients as 65 and ophthalmologic complications as 108. The data collected was based on age and gender of patient, application site of the intraoral local anesthesia, type, quantity and concentration of the local anesthetic, and again type and concentration of vasoconstrictor, which is the main component of local anesthesia. Gauge of injection, cannula, type, onset and duration of the ophthalmologic complication. So by doing a brief study of these articles, the results were concluded and they could show a clear difference in appearance of complications based on genders. Out of a total of 65 case reports with ophthalmologic complications following intraoral local anesthesia, 18 were affected males and 27 were affected females. So we had 27% males and 72% females, which could show a domination of females in these complications. And more than 50% patients had single complication. The mean age of patients was about 33.8 years and the median age was around 31 years. And the age range was from 4 to 73 years, with the majority lying in their third or fourth decades of age. In 37 patients, only a single complication occurred, while in the rest of the patients, they showed multiple symptoms per manifestation. We could see the complications, some of these complications were more frequent than the others, and the most frequent described ophthalmologic complication was diplopia with 43 cases and a total of 39.8%. With a very high rate in females, of course. It showed a solo appearance in many cases, while in others it was associated with other complications as well. Most oftenly, it was combined with mydriasis or porosis. In most patients, it caused paralysis of the lateral rectus muscle. The recovery rate observed was very high, with the exception of 3 cases. The diplopia disappeared completely within 6 hours. So the second most frequent complication we had was ptosis, with 18 case reports and a total of 16.7%. Females again dominated in this case. 70% of patients recovered within 1 hour. It appeared to be related with other complications in more than 90% cases, and mostly with diplopia and mydriasis. In 4 cases, it was related with Horner's syndrome. And after that, the third most important and the most frequent complication we had was mydriasis of the pupil, which included 16 patients and a total of 14.8% of all patients. And in this case, in every third patient, it lasted longer than 5 hours. So after that, the fourth most frequent complication was amaurosis in 14 patients, which formed about 13% of the total. And in 3 of those cases, amaurosis remained permanent. The other reported complications like accommodation, disturbance, and ophthalmos, miosis, and ophthalmoplasia were only observed in few patients. These complications actually showed a wide range of time duration, ranging from only 5 minutes to 4 months, as majority of these complications didn't last longer than 5 hours. The most frequent causes of ophthalmologic complication, we could see that here before that, here we have some graphs which represent onset of ophthalmologic complication and the duration of ophthalmologic complication. We could actually see that these were the it shows the number of patients and the time duration, and represent the basic data of these articles. Now let's talk about the most frequent causes of ophthalmologic complication. Were 2 main causes. They were block anesthesia of the inferior alveolar nerve and of the posterior superior alveolar nerve. The needles used were mostly of 25 gauge, and the anesthetics used were mostly lidocaine and articaine, and their concentration in majority of the cases was less than 2 milliliters. In this literature, we could also had a discussion. We also had a discussion of about various pathophysiologic mechanisms of ophthalmologic complications after intraoral local anesthesia. These were intravascular injection of local anesthetic, reflex vasospasm, cervical sympathetic block, and diffusion of local anesthetic. After intravenous injection, they could reach orbital region and cause ophthalmic complication. Diffusion of local anesthetic agents to the orbit is also possible from the posterior maxilla infratemporal fossa via the pterygopalatine fossa and the inferior orbital fissure. The absence of anatomical barriers and a spine position of the head during administration of intraoral anesthesia favor the diffusion of local anesthetic towards the orbit. So the conclusions taken from these articles were about that diplopia was the most frequent complication, which showed about 39.8% of patients, of which 86.7 were affected with the lateral rectus muscle and abductor nerve, resulting in disturbance of eye abduction. Again, the second conclusion was that all these ophthalmologic complications predominated in females. These could be due to the facial structures or the anatomical differences between a male and a female, as females are most commonly have less facial structures, or to say their size is reduced as compared to male facial structure. So there was a greater probability of the anesthesia to reach into the orbital region. And and the complications were mostly associated with anesthesia of inferior alveolar nerve with 45% in total, and posterior superior alveolar nerve as 41% in total of these cases. So here is an overview of gender, age, onset, and duration of each complication. We could see that the ophthalmologic complications are listed here with their alphabetical order, the number of patients, and how many of them were male, female, and their age, onset of complication, and duration of complication. Here is the reference of this article, and that's all. So thank you very much, and a good day.